in Child and Adolescent Psychiatry from JIPMER. And sir is currently Associate Professor in Sri Aurobindo Institute of Medical Sciences in Indore. And we also have with us Dr. Aditya Agarwal, sir. Sir has done his post-graduation from KGMU, Lucknow. And it's a pleasure to have you, sir. Hidal, sir, Aditya, sir. It's a pleasure to have you today. And I am sure that
Yeah.
after today's session, the residents will have a very clear idea and concept about how to approach a case of NMS, that is neuroleptic migraine syndrome, or migraine catatonia, how to differentiate between the two, and also what is serotonin syndrome, and what are the factors we need to take into consideration, and how to approach and manage the case. So without further ado, shall I start the case presentation, sir? Yes. Okay. Thank you, sir. So for case one, we have a 28-year-old male presented with fever and rigidity. Chief complaints were high-grade fever, severe body stiffness, and altered sensorium for the past 2 days. Patient is a 28-year-old unmarried male with a known history of schizophrenia managed for the past 4 years. Due to recent breakthrough auditory hallucinations and poor medication adherence, he was started on tablet haloperidol 10 mg per day per oral route 5 days ago by his local physician. About 72 hours after initiation, he developed low-grade fever that rapidly progressed to high-grade, documented at 39.5 degrees Celsius, accompanied by generalized muscle stiffness. Over the next 24 hours, he became increasingly drowsy, minimally responsive, and even stopped oral intake. There was no history of vomiting, diarrhea, cough, sore throat, or urinary symptoms. No recent seizures or head trauma were reported. The family denied any substance use or overdose. Examination revealed that patient was diaphoretic, that is, patient was sweating profusely. Temperature was 39.5 degrees Celsius. Heart rate was 128 beats per minute. Blood pressure was raised to 160 by 100 millimeter of mercury. Respiratory rate was 28 per minute. And saturation in room temperature was 95%. Neurological examination revealed severe generalized lead pipe rigidity, mutism, and decreased responsiveness with a Glasgow Coma Scale rating of 10 out of 15. The reflexes were sluggish with no clonus or myoclonus. Pupils were equal and reactive. No signs of meningeal irritation or focal neurological deficit. Lab investigations revealed a raised CPK level, a raised TLC count of 18,000 with neutrophilic predominance, mild transaminitis, creatinine was mildly elevated at 1.4 mg per dl, urine myoglobin was positive, brain CT was normal, brain cultures were awaited. Additional history revealed that along with the tablet that was prescribed with the local physician 3 days, 5 days back, no serotonergic or anticholinergic agents were prescribed. He was only started on tablet haloperidol. No previous episodes of similar illness, no recent infections or travel history. This is the first use of a high potency antipsychotic after a gap of 2 months, because as I have mentioned before, the patient has been non-compliant to the medications and he has been taking the medications irregularly, and there was a gap of 2 months after which the patient was started suddenly on tablet haloperidol by a local physician as per the history. No family history of malignant hyperthermia, which is a genetic condition or similar reaction. So with this case in background and with these neurological findings and laboratory findings, history, I give the floor to Aditya sir and Hiral sir to go ahead and you can have an interactive session with the residents and to go ahead, and the stage is all yours, sir. Yes.
Hello, everyone. Good evening, first of all. Welcome to this session. So you can start writing your diagnosis and differential diagnosis. What could be in this case? It's very clear cut from the history. Everything is almost ruled out, but we would like to hear what are your primary diagnosis and what are your differential diagnosis. You can unmute and respond. That would be better.
I think somebody is
Suresh.
unmuted.
Yes. Yeah.
Raj, you can unmute yourself and answer. Anyone can please unmute themselves and answer, because
Can
you
respond
to
in
be
the
a
chat
very,
box.
yeah.
Yes. Yes, NMS Raj has written. Any other differentials that we would like to keep in this case?
Okay, Dr. Sagnik, can you please just share the screen for the case, just the history details
Sure.
and examination, not the lab findings?
Sure.
Yeah. So I would request all the PGs that if, yes, this is the presentation history, then how would you approach to this case? So we have discussed everything for the investigations further. How would you approach this case? So what Dr. Aditya is asking, that what differentials would you consider? Because you have to start considering differentials right from once you start taking history, and that is how you rule out, and you narrow down to one, possible two or max three differentials, and then based on examination and lab findings and those details, you further reach to a final diagnosis. So generally, for all the residents, this is the thing when you are in the emergency room or in the duty, or sometimes in OPD, that the patient may present like this. So how would you like to approach for further things? And in that case, you can address that what differentials would you like to consider. Uh, if any participant can unmute and discuss, no issues. If it is not correct, it is a learning exercise. Anyone?
I think chat is disabled,
Okay.
and that is why people are not able to
Okay.
respond.
NMS, neuroleptic malignant syndrome, because it is starting after we started the patient on neuroleptic, that is haloperidol 10 mg per day.
Right.
Yes.
Right.
One
Any
is
other
a clear cut.
differential that, like, we must keep in mind when we have such a presentation?
Meningitis.
डब्बा दूंगी मैं अलग से इसे बता दो Nice. That's
Catatonia.
खाली कर ले
Yes.
टीटी रहती है ना वो लक्ष्मण
So yes, EPS is definitely a possibility, and yes, malignant keratonia. Dil Sohaj, can you elaborate on the hypothermia part?
I think, Dr. Sagnik, can we go by one differential that what they have suggested,
Yeah, absolutely, sir.
and then why they have considered this differential based on history, and what
Right.
would they like to proceed further as investigation?
Right.
Is it okay, Dr. Aditya, that way? I mean,
Yes, sir. Yes, sir. So, first of all, one of the field of meningitis is a very common differential in this case.
Right.
So, can you explain why meningitis could be one of the differentials? there is a common reason for hyperthermia. There is also rigidity that can be present in meningitis. So fever and rigidity are quite common presentations in meningitis. Yes. Besides that, autonomic fluctuations can also occur. Yes, altered sensorium can occur.
Yes, we have a very good answer by Sanmukh. I was expecting this answer. Raised ICT features. Any sort of intracranial hemorrhage or intracranial damage, especially in the midbrain region or in that, can also cause certain autonomic fluctuations with rigidity and autonomic dysregulation with body temperature dysregulation. So yes, again, intracranial features, raised ICP is again another. That is why the CT scan was there. With the CT scan, which was found to be normal. So yes.
Okay, so can we start that? How would you approach? I mean, if you considered meningitis, so anyone can unmute and tell the points in favor, against, and the other things that they would like to get the investigations done. To sum it up, I mean, they have put it up. Or Dr. Aditya, would you like to throw some light on that?
Yes. So if you're having a case of fever, rigidity, autonomic disturbance, altered sensorium, what would you like to investigate? In which sequence would you like to go? So first, as we mentioned, if you are suspecting NMS, the first thing to check is for the CPK levels. To rule out other causes of fever infections, we would like to check for complete blood count, and also leukocytosis could be present in NMS as well. Besides that, we would like to see for causes of altered sensorium. So we would like to see for liver function tests, kidney function tests, electrolytes. These can be a cause for altered sensorium. If we are considering other differentials, then we would like to do a neuroimaging to rule out any organic causes, like we mentioned, meningitis or any intracranial hemorrhage, tumor, which could also present in a similar manner. Apart from it, what are the other investigations that we can do? Anything else? If a patient is having severe rigidity, hyperthermia, what are the complications that can occur that we have to look for? Yes. CSF analysis can be done if we have a high suspicion for meningitis, encephalitis. Besides that, we should also look for fundoscopy to rule out raised ICT as mentioned. And KFT, kidney function tests, yes, to rule out causes for altered sensorium, as well as to look for complications of NMS itself. And ECG is also important here, as we are using high dose of psychotropics were used, plus the agents that we will be using to manage it can cause cardiac arrhythmias. And urinary test, particularly for urine myoglobin testing, can be done. These are the basic tests that are to be done in such a case.
Just a practical point on, like, for example, if the urine myoglobin, sometimes they take time to come, or if we are working in some peripheral places where such tests are not available, two things that can easily be done is, one is to check for LDH levels. LDH levels are predominantly raised in NMS. Second is, since the patient is having altered sensorium, if we do a simple Foley's catheterization, we can see the consistency of the urine. And from that, we can have a clear idea that whether there is any if the urine is brownish in color, then we can highly suspect that myoglobinuria is occurring. And I'm sure that Aditya sir will say that once how devastating it can be and how it should be managed, the myoglobinuria and its further consequences. So in peripheral places where such you can't, in the night if the patient comes or in the evening patient comes, you can't do anything very fast. All the investigations, at least one baseline creatinine, urea, and one LFT, and LDH, obviously, which is very commonly done. CK might take a little bit or might not be available in that peripheral setting, and Foley's catheterization with checking of the urine color. These are some, if you're working in a setup where you don't have such easy access to the tests. But as sir said, that is the way to proceed, like stepwise. So LDH, because LDH is predominantly elevated in case of NMS. Uh, Although non-specific, LDH can be elevated in a number of reasons, but in any muscular disorders, LDH will definitely be elevated, whether it be NMS or any other myopathy. LDH will definitely be elevated. So if we get a clear idea about LDH, and if we see that there is the urine is brownish in color, we should definitely, that thing should click in our mind is myoglobinuria. And next, I'll request Aditya sir to take up these points, that how to treat the NMS part and how to treat the myoglobinuria, what are the devastating consequences it can cause, those things, sir. Please.
Yeah, I think what we can do is that, yes, we summed up the investigations about how should we approach, as Dr. Aditya mentioned. So yes, so let us put it this way, that by these investigations, what could be the possible findings in meningitis? What should be the looking in the investigation if they are suspecting serotonin syndrome, or what should be they looking in investigations if they are suspecting NMS? Because those kind of brainstorming will help the, because when you are ordering an investigation, one also has to know what to expect. What to expect, why are you getting this investigation done? Because the possible differentials you have kept, one should also know that in this differential, this would be the finding. So I'm specifically looking for that finding also. So I think if we can discuss a bit on that and then go ahead with the further management regarding, yes, the primary diagnosis of whatever this case is, which is very clear actually, but also managing the complications associated with the NMS. Dr. Aditya, would you like to share something on that about the possible findings in investigations for the differentials that the various participants had enlisted?
So, what about the findings? The first and foremost thing when we are talking about NMS would be CPK. There is a clear indication if the CPK is raised more than 4 times above the upper limit of normal. So that would give a clear indication towards NMS. Besides that, CPK can also be raised in other cases where there is generalized rigidity. So it is not a very specific marker, but the level of increase in CPK is a hallmark of NMS. Usually, if there is generalized rigidity associated with meningitis or other neuromuscular disorders, it would be raised, but not to the extent as in NMS. That is, in NMS, CPK levels would be raised in thousands also. And the cutoff for the criteria is more than 4 times the upper limit. So that would be a clear differentiator. In CBC, leukocytosis can be present in an NMS as well as in infective causes. So it would be a non-specific marker. Besides that, metabolic acidosis is present in NMS also. And among the disorders that we talked about, it can be present in a number of cases also. So not again a very specific thing associated with NMS. LFT and KFT can be deranged. And electrolytes can also be deranged. Particularly, the electrolyte derangement in NMS include the decreased calcium levels, decreased iron levels, and decreased magnesium levels. So these are kind of a little bit more towards the direction of NMS. But out of the all of these, the hallmark feature is the raise in CPK for NMS.
Right.
So any additions that you like?
Yeah, sure. The other differentials that they put, obviously the meningitis, if we go from history, whenever the patient is presenting with hyperpyrexia and rigidity, obviously first the history of any infection, any clinical sign, right? I think as simple as that, the meningeal signs should be elicited. I'm not saying that they would be present or you'll get it all the time, but those are very important when it comes to the clinical examination. Then you find if there are any symptoms or signs of raised ICT, either by clinical history or by examination like fundoscopy, if the papilloedema has set in, or if required, you can go for lumbar puncture, CSF analysis for any specific meningitis. But when it comes to history, the important element we have to see here is one, if you are able to find any precipitating factor or a precipitating drug, like in this case, there was haloperidol. So, what was the event that after which the sequence of events happened? That becomes important when it comes to the history. Clinical examination, the pointers towards uh, NMS in this case would be, I think, fever. And can you please, Dr. Sagnik, mention the share screen for
I'm,
the case?
I'm sharing the screen, sir. Is it visible, sir?
Yeah, for the case.
Yeah, right.
Yeah. So one is definitely that there was an precipitating factor in the form of an antipsychotic. The duration was 72 hours, after which he developed low grade fever, or high grade it developed, and led by uh, muscle stiffness, that is the rigidity. So then drowsy, minimal responsive, and stopped oral intake. So these are the clinical features. Now, if you look for what else should be you looking for? So in the neural examination, that or in the history, the vomiting, diarrhea. So those two symptoms, if you put up differentials of this, one is the serotonin syndrome. So generally, GI disturbances may be present in serotonin syndrome. One has to understand that it is not always yes or no, but it is a cluster of the symptoms when you're taking the history along with the examination and investigation that would lead to the diagnosis. So technically one element of serotonin syndrome can be ruled out because there are no GI disturbances. And when it comes to examination, what is typical of serotonin syndrome, that we'll discuss definitely in the next cases. But the neuromuscular abnormality of NMS and of serotonin syndrome, of malignant hyperthermia, and some anticholinergic toxicity or one or two meningitis, this would be different, right? Yeah, somebody, Sudesh, mentioned very well the myoclonus, which has become a major criteria for the Hunter's criteria, which has superseded the old, I think, Sternbeck's criteria. I don't remember the name exactly. But yes, so here it will be more of a hypostate that will be led by rigidity, right? Hyperreflexia and myoclonus are more or less part of hyperreflexia, and myoclonus are more or less part of serotonin syndrome. So history, physical examination, and then investigations. Investigations, Dr. Aditya mentioned very well that what should be considered, what level of CPK rise is suggestive of NMS. CPK rise could be possible because of multiple conditions, right? It could be also possible if there is a severe physical injury to muscles, right? So, but what level, along with the preceding history of antipsychotic or any dopamine blockade, with the clinical features of hyperthermia and rigidity, with some autonomic instability, examination suggestive of lead pipe rigidity and fever, right? So these are more suggestive of NMS. Clinically, we differentiated, and investigation wise, as Dr. Aditya mentioned, that is how we differentiate. One is the level of CPK. Obviously, there could be leukocytosis in any of this, meningitis, serotonin, or NMS, right? But the CPK is more or less specific. And the other thing, the level of the rise of CPK is more or less more specific or inclined towards NMS. And obviously, the other investigations like electrolytes, as Dr. Arita mentioned regarding phosphate, calcium. Yes, as Dr. Sagnik mentioned, that not every investigation will be available at every place. We were privileged to work at institutions where probably these were available. But if you're not able to do that, at least the other electrolytes are important, if not for diagnosis, for managing the complications, right? Hyperkalemia, hyponatremia, if there is a serotonin syndrome that is leading to significant fluid loss, leading to hyponatremia, that could lead to seizures. So all the management also becomes equally important, right? Uh, Dr. Aditya, can we now discuss a bit about the NMS or?
Yes, sir.
Just this finals on small things, sir.
Dr. Sagnik, please.
If is my screen visible, sir?
Yes,
Yes.
it is.
Yeah. So this is taken from standard textbook of Maudsley as well as the recent CTP and the last Leishman. So what they clearly state is that the Levenson's diagnostic criteria for NMS, the major criteria, because this is often asked as a Viva question, that hyperthermia, as we said, hyperthermia, temperature exceeding more than 38 degrees Celsius, muscle rigidity, and elevated CPK, as sir mentioned, more than 4 times, that is more than 1000, is the three major criteria. Now, there is actually one more major criteria which is not mentioned here, that is any exposure to a neuroleptic agent in the last 72 hours. So this time duration and exposure to a neuroleptic agent is also very important for diagnosis. In minor criteria, we have the tachycardia, hypertension or labile BP, tachypnea, altered mental status, diaphoresis, leukocytosis, metabolic acidosis. So as per Levinson, at least 2 major and 4 minor criteria are required. And DSM-5, though it doesn't give proper criteria, still it mentioned that exposure to dopamine antagonists, neuroleptics, or withdrawal of dopaminergic drugs, this is also an important part. Severe muscle rigidity, fever, autonomic instability, altered mental status, and laboratory findings. So I think this more or less sums up the diagnostic criteria, differentials, and the approach and assessment of a patient with NMS. Now, I will request Aditya sir to talk about the what are the various myriad of complications that can happen due to NMS, and how to tackle each one of them, and how to treat the NMS itself. Dr. Aditya sir, please.
Yes. So we'll start with complications. So first of all, let's understand why are we so worried about NMS? Why it is such an important topic? What is our fear? What can NMS lead to?
I think apart from the question in an exam or a Viva, clinically, why it is so important?
Yes,
Mortality.
mortality.
Yes.
So it is one of those conditions in psychiatry where mortality is a higher risk, is at a higher risk in compared to all the illnesses that we deal with. NMS is one syndrome where we have a high risk of mortality. Now, how high is this risk? What percent of NMS patients actually have mortality? 10 to 20, maybe not 10%. So it varies. Overall, the rate is about 5%, and in ICU, if the patient requires ICU admission, the rates can go up to 20%. So which is a very high risk in terms of psychiatric conditions. So that is one of the major reasons. Now, let us talk about what are the reasons for mortality. Why can a patient with NMS die? What can lead to death in NMS? Acute kidney failure, myoglobinuria, yes. Severe dehydration, which would lead to again cardiovascular collapse. Respiratory, not exactly paralysis. No, respiratory drive is not as such affected. Electrolyte disbalance. DIC again, not as common. It is much more common with serotonin syndrome, but can occur here also. What else?
I think what he meant was probably if NMS there is prolonged and if you're not taking care of the posture changes in that, then yes, there could be, thrombosis and all those things. But yeah,
Yeah.
as Dr. Aditya mentioned, not one of the primary direct uh, leading causes for DIC is not NMS.
Hmm.
Aspiration pneumonia.
Yes, aspiration
Rohit has a
pneumonia.
very good answer. There is misdiagnosis.
No,
This
we have diagnosed it. We are sure about our diagnosis. We have
yeah.
diagnosed as NMS, so that we have already done the exercise.
Yeah.
I think
So
would
we are
anybody
clear.
like to throw some light on electrolyte imbalance?
Yes, that is very yes. Yes, please.
Septic shock.
Those are long-term complications. Let me just phrase it like this as Hiral
Yes,
sir
yes,
asking.
yes.
Yes, already we got the answer.
Hyperkalemia and
Hyperkalemia,
arrhythmia.
which is definitely one of the primary reasons to look out for NMS.
So hyperkalemia, hypocalcemia. So these are the reasons for mortality. So this this is the set of complications that we are acutely very worried about. What about the other complications? So what are the other sort of less severe complications of NMS that we need to manage and settle? So the patient is rigid, has fever, temperature, rapid BP fluctuations. What else can occur to the patient? Hepatic encephalopathy, no, not as commonly. It can lead to a number of some raise in LFT, but not so severe to cause as hepatic encephalopathy. Bed sores because of the same continuous posture. And strong, if your muscles are tightened for a very long duration in the same posture, what can it lead to? Fractures, not so much, but yes, some kind of some injury. Contractures, yes. And also compartment syndrome can occur in cases. Apart from it, we forgot cardiac complications, so arrhythmias because of secondary to electrolytes or just because of the dopaminergic dysregulation, that too. And in long term, it can also lead to brain injuries, cerebellar dysfunction, and Parkinson's remaining movement disorders later on. It can also lead to such movement related disorders in the long term. So these are the
Just
basic
one small point, sir. NMS was also previously called, though it directly doesn't cause respiratory failure. Like in case of dystonia, we can get laryngeal spasms. But still, NMS was previously called as barrel chest syndrome. So that is, if the chest muscles, that is the respiratory muscles, they are paralyzed, then the patient often requires intubation or ventilation of some kind, at least till the crisis is this thing. So that is also one of the thing why NMS should always be managed in an ICU, because the patient can develop the barrel chest syndrome or respiratory muscle spasms at any point of time, contractions, and we may need to put the patient on ventilation. So always we should try to manage this patient with regular monitoring, and because ABG and all these things, as sir said, is required, we need to monitor the patient in an ICU setting.
So now we know what the complications are. We have answered majority of the complications. So now if we suspect that the patient has NMS, we have diagnosed that the patient to have NMS. So what is your first step in management? What is the first answer that you would say? Yes, stop neuroleptics.
Wonderful.
So this is the first step. Do not miss this step. So even when you write theory answers or say in Viva. stopping the offending drug is the primary thing. Then the second priority would be
Maintaining hydration.
Yes, yes.
more in a much more broader sense. Let's say uh, stopping the mortality, reducing the risk of death. To reduce the risk of death, what all should we do? We should first get them into intensive care units so that there is proper monitoring. Second, stabilize the airway, check the patency of airway, breathing, maintain saturation, circulation. This is the important part in NMS. Why? Because there are autonomic fluctuations commonly. So here circulation has to be maintained, and how would we do it? Through IV fluids. And what would be the preferred choice of fluids here? Would you like to give ringer lactate? No. Why? Because we are already in an acidotic state, and muscle tensed hypertonic muscles would again lead to increased lactate levels. So RL is not preferred here. We'll use normal saline, and if the patient is not orally feeding, then maybe dextrose also as per the glucose levels. So this would be the third step of management after ensuring airway breathing, then circulation. In circulation, do not miss out that we also have to look at the cardiac status and see for the ECG and manage arrhythmias there. Next would be the step to prevent the long-term complications here. So prevention of bed sores, preventing aspiration, putting the patient in a propped up position, not feeding the patient in lying down posture, as the patient would not be able to move it. Frequent posture changes, mobilization as pointed out. And if there is high risk of contractures or compartment syndrome, so that should be looked out actively in this patient. So A, B, C, and D. D was for disability prevention, so long-term disability prevention. And this also we look for managing the fever. Fever, there is high grade of fever with fluctuation. So again, IV paracetamol or other NSAIDs can be given. That is extremely important. Now the third major step is to actually treat the core symptoms of NMS, that is the rigidity. So for rigidity, what is the mainstay of treatment?
One small thing, sir.
Yes.
Like as sir said, that in the ABCDE, the one of the most important steps is, as sir said, is aggressive IV hydration. Because aggressive IV hydration, in this case that I presented, as you can see, already AKI has started to set in with 1.4 of creat. That means that the AKI has started to set in due to rhabdomyolysis, leading to myoglobinuria, leading to renal tubular damage, interstitial damage, leading to AKI. So in this case, the only way to get rid of this thing is, there are two types of AKI. One is oliguric AKI, one is non-oliguric AKI. Now, in this case, we are having a non-oliguric AKI case. So we will give the patient aggressive hydration so that all the myoglobins, they are flushed out without causing significant interstitial damage to the kidney. So at least we need a urine output when we do IO charting, urine output of at least 3 to 4 liters per day. That means we have to hydrate the patient with at least 5 to 6 liters of NS per day. So yes, obviously catheterization and all these things to monitor the IO chart and all, that is the important part in the secondary management. Now, Aditya sir, let's, as you said, we'll move on to the core management symptoms, like how to manage the NMS part, sir.
So now, yes. So now, if we want to treat NMS, first we need to understand why is it happening? What is the primary agent that is causing it? It's a dopaminergic antagonist. So to treat dopaminergic antagonist toxicity or side effect, what would we like to give? or dopaminergic agonistic drugs. What are the dopaminergic agonistic drugs that we know of? Levodopa, amantadine, levodopa carbidopa combination, and bromocriptine. Yes. So out of these, what is the first line that we can try? So bromocriptine. Yes. So we'll go with bromocriptine is one of the first choices of treatment in NMS. What is the dose for bromocriptine? Anybody? Dosage of bromocriptine. Yes. As Prashant mentioned, 2.5 mg starting at BD or TDS dosing. So it comes in a tablet of 2.5 mg. You can start with half uh, twice a day to thrice a day, and you can gradually increase up to 45 mg of bromocriptine per day. And how long would you like to continue it? So what is the half-life of the drug that we stopped? What is the usual half-life of antipsychotics? Yes. So again, 1 to 2 weeks. So an approximate 10 to 14 days, we would like to continue bromocriptine. So do not withdraw bromocriptine or dopaminergic agonist very early on in the NMS, then that can lead to worsening of the symptoms. Apart from bromocriptine, which is the second drug that we can give? Amantadine. Yes, we have come for rigidity in the next part. So amantadine is the second drug that can be given. Amantadine, dosing for amantadine? It's 100 to 200 mg twice a day. You can start with 50 mg BD, TDS dosing and increase to up to 200 to even 400 mg we can give. And the third, but less common choice would be levodopa carbidopa. Why? Because the half-life of levodopa syndopa is very short. So you have to give much more aggressive dosing. And it's a pure agonistic drug. So it can lead to worsening of the core psychotic symptoms that are present. Amantadine and bromocriptine would be a much better choice. The last step in management would be to resolve the rigidity. So what all drugs can we give to resolve rigidity? Yes, so muscle relaxants, dantrolene is the choice. Dantrolene can be given for rigidity. What is the dose of dantrolene then? We start with a slow dose of 1 mg per kg per day. We can increase up to maximum of 10 mg per kg per day. And again has to be continued for at least 7 days, followed by 7 days of oral treatment as well. Dantrolene is difficult to acquire. It is not usually available. And so you might not encounter yourself using dantrolene. And so what other kind of muscle relaxants can we give?
Anticholinergic like procyclidine.
Anticholinergics are
Too much
not
drink.
Anticholinergics are actually not that much
not
indicated
indicated.
in NMS, basically, because already you are having, if you see Apurva, the consciousness, there is alteration in sensorium, there is fluctuation of consciousness. So you can call it a type of delirium. So whenever the patient is any sort of delirium or altered consciousness, any sort of anticholinergic drug is not preferred, because it suppresses your reticular activating system and the pediculopontine nucleus, from where mainly the acetylcholine is secreted, which is an arousing agent. So what happens is basically you are worsening the delirium. So there is something called anticholinergic burden scale. So anticholinergic is something that we often do not when a patient is in delirium due to any cause, like NMS is also a type of delirium with altered consciousness. So definitely anticholinergic is something that we shouldn't think of in the first place. Many people give. Yeah, we have got the answer, sir. I think we have got the answer.
Yes. Uh, so the next would be to give other muscle relaxants. So baclofen can be given,
Yes.
and even benzodiazepines act as a very good muscle relaxant.
Yes.
As we talked last time in APS and even in dystonia, lorazepam injectables are very effective in resolving dystonia. So lorazepam is also one of the preferred choices. So it can be given IM, IV, and orally. So a test dose of 2 to 4 mg can be given, and then if there is a good response, again you can go ahead with oral lorazepam. And if you do not have lorazepam, even clonazepam is given in high doses. The high dose can be up to the range of those that we use in catatonia. So up to that range also we can give. And last, if nothing is working, then what is the last resort to treat NMS? If despite a lot of medications and benzodiazepines, if the patient is not stabilizing, then ECT. ECT is one treatment that is effective even in NMS. Sir, over to you to add
Yeah, I
any point.
think you very well covered it right from that. If you look for the history, the offending agent, the clinical features, what investigations would you do to differentiate and rule out the other things to reach to a diagnosis, whether this is NMS or serotonin syndrome or malignant hyperthermia, and then regarding the management of first what needs to be done, right? And then reducing the complications and reducing the mortality, as Dr. Aditya mentioned. So understanding all the complications and all the mortality related reasons, then we work on that. And then the primary dealing the primary reason of NMS being the dopamine blockade. So either we give bromocriptine, amantadine, those dopamine agonist, or you go for dentrolin, which is basically acts by, I think, the it has a mechanism on the intracellular calcium influx, and that is how it releases or leads to muscle relaxation. So that is very well discussed. So I think, Dr. Sagnik, we can go to the next case.
Sir. Sir,
I think
just
we can.
couple of things, sir.
Yeah, please.
Sir, as Aditya sir poignantly pointed out, that dantrolene sodium, even when I was posted in a NIMHANS and even in my own institute also. So when a case of NMS will come, so as in my first year, I still remember as a freshly passed out graduate, I was because in NEET PG we are trained to answer dantrolene, dantrolene, dantrolene. I was shouting dantrolene, dantrolene, and then I was told that we don't have that supply over here. We have baclofen. We'll give baclofen dose of 40 to 60 mg. We'll start with 20 mg BD and we can go till 60 mg, 80 mg also. So that is a very good muscle relaxant. And I think there was a question regarding that how does ECT work in NMS? So regarding this question, I will just say a couple of points that there are many pathophysiological, the neurobiological underpinnings of NMS. We'll move on to the next topic, and in the next topic, we'll quickly before moving on over to serotonin syndrome, we have a small topic in between, and I will request Aditya sir and Hidal sir to just because this topic is very much related to NMS and they are often misdiagnosed or diagnosed together, though the role of ECT is much more in the latter than in the previous, that is malignant catatonia. So I will just present a case of malignant catatonia, and then I can further elaborate that what is the role of ECT in case of NMS or malignant catatonia for that reason. So shall I move on to the next case, sir?
Yes, yes.
Okay, sure.
Yeah, right. So 35-year-old woman with mutism and refusal to eat and abnormal posturing for the past 5 days, followed by fever and autonomic instability. So first there was refusal to eat, mutism, and abnormal posturing, and it was followed by fever and autonomic instability. HOPI. This 35-year-old woman with a 10-year history of bipolar affective disorder had been in remission for over a year while on maintenance of lithium and olanzapine. 3 weeks ago, she experienced mood fluctuations and reduced sleep, which evolved into psychomotor slowing, reduced speech output, and eventual mutism. Over 5 days, she became completely nonverbal, refused all oral intake, remained in bed in a fixed posture for hours, and developed episodes of sudden agitation. She was brought to the hospital after family noticed fever, profuse sweating, and abnormal breathing. There was no history of new medications, seizures, drug overdose, or systemic infection. No known history of epilepsy or head trauma, no recent changes in lithium dosage. The patient had previously experienced catatonic symptoms during a manic episode 4 years ago. Examination findings: patient appears stuporous with a blank stare and minimal spontaneous movement. Temperature is high, 38.8 degrees Celsius. Tachycardia is present at 110 beats per minute. Blood pressure 150 by 90 millimeter of mercury, which is on the higher side. Tachypnea is there with respiratory rate of 24 per minute, and SpO2 is 96% in room air. Patient displayed waxy flexibility, posturing, echopraxia, negativism, and mutism. Rigidity was present, but not as extreme as lead pipe stiffness. Reflexes were normal. No clonus or hyperreflexia was elicited. Pupils were equal and reactive. GCS was 9 by 15. Laboratory investigations: CPK was 1200. IU per L. WBC count was 14,000. Serum electrolytes and RFT were within normal limits. Liver enzymes were mildly elevated. Mild transaminitis was noted. Brain imaging, neuroimaging was normal. Blood culture and chest X-ray was normal. Serum lithium level was 0.06 milliequivalent per liter, which was within therapeutic range. Additional history findings: no recent changes in medications or dosage, no serotonergic or dopaminergic drugs introduced, no tremor, hyperreflexia, or clonus. Lorazepam 2 mg IV trial led to transient reduction in rigidity and slight eye contact. Family noted similar symptoms during past manic episodes, though less severe. No family history of movement disorder or psychotic illness. So now, with this thing in mind, actually catatonia is a whole different arena. Is a with this case in mind, since we have also serotonin syndrome to discuss, which is a much bigger topic, I will like to move to Aditya sir and Hiral sir. Not to focus on the symptoms that we talked about, about the mood disorders and the negativism, the mutism, the waxy flexibility. Not to go into all these things, but what are the core features which we can take away from this case? If you can give it a nutshell, that malignant catatonia, how to differentiate it from NMS, how is it differentiated from NMS, and what is the management of it, how to assess it and manage it in a nutshell. Then we can move on to our bigger topic of serotonin syndrome, because often students are in Viva and in practical life also, we are confused that whether this is NMS or malignant catatonia. So how to approach that
Yeah.
and the management part. Over to you, sir.
Yes. So, as Sudesh wrote, malignant catatonia is our primary diagnosis in this case. And So just to point out, what is the primary difference between a malignant catatonia case and an NMS case? Can anyone mention what is the major point of difference? No increase in psychotropic dose, exposure to antipsychotic. Yes. So as one of the questions was also there, can we label NMS due to idiopathic cause or due to underlying psychotic disorder? So no, NMS, for the diagnosis of NMS, we need to have a history of antipsychotic or dopaminergic antagonist drug exposure in the last 3 days. This is one of the primary things that you have
Because
to
in the
look for
major
in the
criteria
history.
also of Levinson, the first criteria of Levinson is that exposure to any neuroleptic agent in the past 72 hours. So NMS can never be due to any underlying cause, unlike this case 7. Please.
So, so the first and foremost thing, the history of antipsychotic drug exposure. But like in this case, there can be history of some of the other psychotropic use if we are looking at a patient of catatonia. So there can be a history of, so again, clinically in practice, you may not be able to differentiate malignant catatonia from NMS based on just on the history. The next thing that is the key difference between malignant catatonia and NMS, as Dr. Naini, as Pravidhi had pointed out, the presence of catatonic features. So the typical classical hallmark catatonic symptoms and signs, the posturing, waxy flexibility, echo phenomenon, automatic obedience, all of these are the hallmark signs for catatonia. And if they are present, the diagnosis is much more likely to be malignant catatonia. Apart from it, there is no clear-cut differentiator between malignant catatonia and NMS. Rest of the things can completely overlap. Only the presence of catatonic features is not present in NMS. So rigidity can be present in both cases, but here it could more be of Gegenhalten type or of axis flexibility type, whereas in NMS it would be a classical lead pipe rigidity or sometimes cogwheel rigidity. So that can be present. The next question is about CPK levels. Both can be raised in both of the cases. CPK is not a diagnostic entity. Only the in percent or the amount of rise can point more towards NMS. Reflexes again can be variable in both the cases, in NMS as well as in catatonia. Lorazepam challenge test again can falsely be positive in NMS. Like we discussed, lorazepam can lead to muscle relaxation in NMS. So that is the key thing that you have to remember.
So I think to sum it up, it's just like, I would say that catatonia plus hyperthermia plus autonomic disturbances, that is malignant catatonia. If you keep it as simple as that. Barring catatonic signs, if the other things are present, possibility of NMS. Right. So yes, then the rest of the things may not, because in practical world, first of all, if you see, when you see the patient and you see the prescription, he will be at least on not just antipsychotic, two antipsychotic, one mood stabilizer, one benzodiazepine, maybe one SSRI. So that is a very routine practice. So yes, it becomes difficult history wise to ensure that if a drug naive patient and first started and presented, that is a different thing. But many times they come with polypharmacy. So the clinical examination also becomes very important. So yes, catatonia itself is a very big topic. So, but how eliciting the catatonic signs becomes very important when you are putting a differential. I think Dr. Sagnik, can we
Yes.
move to the next case?
So just 2 points to add, sir.
Yeah, sure.
One very funny point also. So actually, this for one of the core symptoms of malignant catatonia is that it won't respond to the classical bromocriptine or that is managed when we manage the core symptoms of NMS, like bromocriptine or levodopa carbidopa combination or amantadine. It won't be responding to that. The only and only management of malignant catatonia, apart from lorazepam challenge test, still is the modified ECT. Now, how it is involved, there's a huge neurobiological pathway, and I had from conceptual psychiatry team, we had shared the whole neurobiology of catatonia, and also that how the ECT that we induce generalized seizures, they restored the chemical imbalance. That is, if it in case of NMS, it will increase the dopaminergic secretions in the dopaminergic pathway, that is in the nigrostriatal pathway and the other pathways. The dopaminergic transmission will be increased, and in catatonia, due to GABAergic stimulation, the rigidity part that had set in mainly due to glutamate dysfunction or dopaminergic dysfunction, that also will settle down. So it's a huge the neurobiological underpinnings are massive, and if you look into the neurobiology, you will understand that exactly at what point can GABA be inhibited and dopamine can be increased, or dopamine can be inhibited and dopamine can be increased in some parts. So that is one point, neurobiological underpinning. Another interesting fact is that we will discuss this further in catatonia, is that in catatonia, as in the book of Max Fink, they say that 70% of catatonic patients have mood disorders. So bipolar disorder in this patient is a very common indication of the patient having catatonia, because as Fink says that managing catatonia is just scratching the surface of a mood disorder. So as said before, that the patient was having manic episode and catatonia, so that is also points towards catatonia. And recently, as I mentioned, I had seen a prescription of a private practitioner, and the patient was on patient had landed up in catatonia. Patient was on chlorpromazine, trifluperazine, amisulpride, fluvoxamine, lorazepam, and it was like we couldn't even. So it becomes very difficult to understand it clinically. And also one small thing, that whenever I think many residents also will think about this, that in the whenever we give ECT, the anesthesiologists, they are very scared to touch the patient, because they feel that we are defibrillating the patient, and they will move away from the patient thinking that they will also get electrocuted. So I often tell them that this is not defibrillation. You can even hold the patient down if you want, or touch the patient. The MECT is a very safe procedure, and you won't be electrocuted in the procedure. So with that thing, we'll move on to the last topic of the day, that is serotonin syndrome, and I will present the case. So the case 3, we have a 24-year-old woman with agitation and tremors. Chief complaints: restlessness, involuntary shaking, and diarrhea for 1 day. History of presenting illness: 24-year-old woman with a recent diagnosis of moderate depressive episode was started on fluoxetine 20 mg per day by her psychiatrist 10 days ago. For menstrual cramps, her primary physician prescribed tramadol 50 mg TID 2 days ago. Within 24 hours of starting tramadol, she became increasingly restless, anxious, and began experiencing tremors in her limbs. She also had episodes of loose stools, that is diarrhea, excessive sweating or diaphoresis, and intermittent or fluctuating confusion. There was no history of fever prior to medication, no seizure, and no alcohol or illicit drug use. She denied any suicidal ideation or overdose. There was no recent trauma or infection. Examination findings: on arrival to emergency, temperature was 38.6 degrees Celsius, which is slightly on the higher side. Heart rate was tachycardic, 115 beats per minute. Blood pressure was 145 by 85 millimeter of mercury. Respiratory rate was 24 per minute. Oxygen saturation was 98% room temperature. Patient was agitated, anxious, and confused. Neurological examination showed marked tremors, bilateral hyperreflexia, and inducible ankle clonus. Pupils were dilated and reactive. No rigidity or bradykinesia was noted. Mild horizontal ocular clonus was observed. Skin was flushed and diaphoretic. Lab investigations. Total leukocyte count was 13,000. CPK was mildly elevated to 450. Serum sodium and potassium was normal. There was respiratory alkalosis. ECG patient was having sinus tachycardia. And urine toxicology was positive for tramadol because it is an opioid, and negative for other drugs. Additional history findings: no antipsychotics or lithium prescribed. That is, that can cause those tremors and all. No rigidity, but motor overactivity or hyperactivity noted. Recent addition of two serotonergic agents, that is one SSRI, that is fluoxetine with tramadol. No prior psychiatric hospitalization. No previous similar episodes. No family history of epilepsy or psychiatric illness. With this case scenario, I will like to give the platform to Aditya sir and Hiral sir to further elaborate on this topic. Sir.
Yeah, Dr. Aditya, can you please? I think we discussed a lot about the clinical features and the investigation. So if you can just briefly touch the differential physical findings in this case, because role of investigations we discuss in the detail when we talk about the first case, and then move on to the specific part of the management.
So what are the key findings that you saw were different from the rest of the two cases? What are the findings that are particularly characteristic of serotonin syndrome? Hyperreflexia, clonus, ankle myoclonus, hyperreflexia and clonus. What else?
No rigidity.
GIT disturbances. Yes, Apurva, sorry.
No rigidity, sir.
Can anyone also focus on the history part? One catch point, as it was in NMS. Yes, a serotonergic
SSRI
agent.
combination.
Yes.
Fluoxetine tramadol. Mydriasis. Yes. Mydriasis is also one of the differentiating features. Else, diarrhea. Yes, very common in serotonin syndrome. Respiratory alkalosis. Respiratory rate can be increased in serotonin syndrome. Rigidity was not present in this case, but rigidity can be present in very severe cases of serotonin syndrome. So not a clear differentiator. Tremors, yes. Tremors can occur, particularly in early stages or mild cases of serotonin syndrome. Tremors is common. Flushing, sweating, again common with NMS also. Not a clear differentiator. Yes, so these are the core differentiating features. So how can we diagnose serotonin syndrome? Is there any criteria? Because there are a lot of overlapping symptoms between NMS and serotonin syndrome.
If you allow, sir, I
There
will
are
just
specific...
share my screen, sir. And
Yeah.
you can just
So there are specific criteria both for NMS, as we discussed Levinson's criteria, and there is also a specific criteria for serotonin syndrome. The earlier historical one was Sternbach criteria, and currently we use the Hunter serotonin toxicity criteria, or Hunter's criteria, we can just remember it as. So it is a difficult criteria to exactly remember, but one is that, again, offending agent should be present. use of any serotonergic agent in the past few days. So here the onset of serotonin syndrome usually occurs within 24 hours of an increase in dose or a combination of serotonergic drugs being taken, plus the presence of one characteristic feature or a combination of some of the characteristic features. So even if there is presence of spontaneous clonus in the patient, then we can diagnose it to be serotonin syndrome. And if there is inducible clonus or ocular clonus, then the presence of agitation or diaphoresis is sufficient to diagnose it. Besides that, hyperreflexia, tremors in combination is also sufficient. And lastly, hypertonia can also be present. So rigidity is not a clear-cut differentiator for NMS. Rigidity can also be present, but in extreme cases. And next, so this is the severity classification as it is shown by Dr. Sagnik. So in initial stages, in milder cases, there is only tremors, hyperreflexia, diaphoresis, and some anxiety or mood disturbances. Here also an important point is mood symptoms or changes in cognitive symptoms are much more common in serotonin syndrome. So you can see patients can also have manic symptoms, euphoric symptoms in serotonin syndrome that can be a result of the switch that can occur because of antidepressant. Moderate, and as we go with moderate and severe cases, there can be hyperthermia, and the classical hallmark of serotonin syndrome, although not a part of the criteria, with one common thing that we have to see is the hyperactive vowel sounds or the presence of diarrhea, vomiting. So that is very common. Why is it common? Because serotonin is predominantly present in the GI tract. So GI symptoms are very, very common in serotonin syndrome, which is not almost never present in NMS or in catatonia. So that would be the specific features for serotonin syndrome.
And as over here, you can see that in the toxicity criteria, the focus on clonus as key feature, as Sarah said, is one of the key feature is that either spontaneous or inducible clonus. And the other factors are obviously as discussed in the criteria. So, shall we move on to the management part, then, sir?
Yes. So for management, we have to first just go through the drugs that can cause serotonin syndrome. So what are the drugs that we know can cause serotonin syndrome? There are a number of drugs that can lead to serotonin syndrome. Their combinations. Yes, SSRIs definitely. SNRIs. Next. What else? MAO inhibitors. Yes. Apart from it, there are a number of drugs that have some low level of serotonergic action that when given in combination can lead to serotonin syndrome. So these include the triptans. Very commonly, we have comorbid migraine and triptans are prescribed. So this is often overlooked. So presence of use of triptans is there. TCAs, yes. Amphetamines, cocaine in combination can also lead to serotonin syndrome. Apart from it, in this case, tramadol, because it has a serotonergic and partial SNRI-like action. Apart from it, St. John's warts and some antibiotics like linezolid can also lead to serotonin syndrome.
So I think somebody asked lithium plus SSRI. Yes, I think there's some
Yes.
literature regarding lithium.
Can happen. Can happen.
Yes.
Lithium can cause a wide
Sensitizing, yes, it can also sensitize the receptors. So
Yes.
yes. So as Dr. Aditya mentioned,
Yes.
the important thing to remember is the list. The list is, I won't say exhaustive, but yeah, those drugs which could be given on day to day, I mean, on simple basis like, dextromethorphan in cough syrup, some antibiotics, macrolides, painkillers in the form of tramadol. So those interactions become important whenever you are suspecting. So history about the list of the drugs that were going on to the patient becomes here important. And the second thing I would like to point out before going further in the management is these cases highlight that what is the importance of understanding the neurological examination and performing it well as a psychiatrist also. These are the neurological examination differences that can help you uh, find the possible differentials and rule out the other possibilities. So yes, it's very important. As a psychiatrist, it does not mean that the neurology is not important. It's equally important, especially the neurological examination one should be thorough with. Yes, Dr. Aditya, we can go ahead.
Sir, before moving to management, sir, just one point, sir.
Yeah, please.
Actually, regarding the serotonin syndrome, so usually I tend to get into a lot of verbal academic discourses with neurologists. So recently, actually, I was having an academic discourse in a group with neurologists, and actually, they were saying that serotonin syndrome is not so common. But in my 3 years of PG, actually, I have seen quite a few serotonin syndrome patients, and I presented to them with the data. And more often than not, the cases, true, it's true that some drugs that we use, as you mentioned, sir, like dextromethorphan or tramadol, fentanyl, triptans, they can cause serotonin syndrome. But what we as psychiatrists need to be more aware of is, suppose we are treating a patient with treatment resistant OCD. Patient is on fluoxetine 80 mg, and we have started clomipramine. We have made clomipramine till 125 mg, 200 mg. Very high chance patient can land up in serotonin syndrome. Again, in personal, we have a case that we have documented in our institute only. Patient was severely depressive episode, not much responding to any medications, and they were diffusing ECT. So we decided to start tranylcypromine, that is available by the name of Trivon. So tranylcypromine, as you know, is a non-specific MAO inhibitor, that is monoamine oxidase inhibitor, and it's a very potent drug because if you see the STAR-D trial, it is the final drug that comes is tranylcypromine. So we started the patient. The patient was already on venlafaxine. We started on Trivon, that is tranylcypromine. Patient, in few days, patient was up and about. The depressive features were starting to resolve. Patient landed up in serotonin syndrome. So MAO inhibitors, again, moclobemide, phenelzine, tranylcypromine, we have to be very careful about them. And when we are treating OCD patients with very high dose of TCA or SSRI, or we are using multiple SSRI at a point of time, or SSRI plus SNRI sometimes we use, we have to be careful about the serotonin syndrome. Sir, we can finally move on to the management part now. Aditya, sir.
Just one thing before that. I think for MAO, it's clearly said that 2 to 3 or 2 to 4 weeks of washout of the previous drug. So that
Yeah.
is equally important. So as you mentioned, I just wanted to highlight that Maudsley or certain books have this wonderful chapter about drug interactions. And at times when you're using those drugs that are not commonly used, I don't think there's shame in going back to the books and referring it again.
Yes.
The point is that you should know what and where to read. Right. So understanding those drug interactions, see, it is about not more about the single agent. It generally happens when there is a combination
Multiple. Yes.
or polypharmacy with a higher dose. So that is where the interaction becomes important. That is what I want to highlight. I think we can go ahead with the management.
Yes, so another important point we need to remember is the combination of SSRI plus TCA is only as such theoretically indicated or in guidelines only for treatment-resistant OCD. Apart from it, when we are treating unipolar depression, a combination drugs of SSRIs or serotonergic agents are not recommended, and you do not have to use that as an answer, even though it can be seen quite commonly in practice. But no, the combination needs not be prescribed. No such combination needs to be tried.
Yes.
Now,
I mean,
talking
absolutely.
about
Like, if you see that, I mean that we should always refer to the STAR-D trial, because I think in study trial they have very nicely put upon all the from citalopram to bupropion to nortriptyline. They have compared everything, and they have told about augmentation strategies also with lithium or T3, and then to California rocket fuel of mirtazapine venlafaxine. So those things are come very important rather than starting on 2 3 antidepressants at the same time. So yes.
Yeah, I think regarding that, that could be altogether different topic. How
Yes,
to
yes, yes.
evaluate
Like,
for restraint things.
so it has
Yes, the important point is combination should be, yes,
polypharmacy.
Dr. Aditya
Polypharmacy is
mentioned,
definitely.
it has to be taken care of, not used, not to be answered in the examination until and unless couple of things if backed by evidence, otherwise no.
Yes.
Yes, Dr. Aditya, please.
So finally, moving on to the managing serotonin syndrome. So again, let's start. What would be the first step to manage serotonin syndrome? For any adverse effect, what is the first step?
Stop the offending agent.
Yes, so stop the offending agent. We should completely withdraw the interactional agents or the combination of drugs that we are using. And next, what are the complications or the dangers that we need to take care of immediately in serotonin syndrome? What can the patient die from in serotonin syndrome? In dehydration, there is lot of diarrhea, vomiting, so poor intake, so dehydration, as well as in severe cases with rigidity, metabolic acidosis, and on the similar lines of NMS. So that section of supportive care of treating the hyperthermia, of treating the muscular rigidity remains almost similar to NMS, except the fact that we are not going to use dantrolene because we do not have such a severity of rigidity here. Now, let's talk about the core symptoms. So we have the core symptoms of, what are the core symptoms here in serotonin syndrome? Yes, so one of the questions is, does the patient need ICU monitoring? Good question. So that depends on the severity of serotonin syndrome. In milder cases, you can always manage serotonin syndrome even on OPD basis or even at a routine inpatient setting or at a couple of days of short admission. But if the severity goes beyond moderate severe, there is hyperthermia, hypertonia, agitation is present, there is confusion or delirious features coming in, there is severe vomiting, there are signs of dyselectrolytemia, then you require an ICU admission. So now talking about the core symptoms of serotonin syndrome, the first symptom that we talked about is commonly are the hyperreflexia, myoclonus, and the agitation. So for this, the one of the key drugs that we can use is to benzodiazepines. So benzodiazepines would act as a muscle relaxant, would reduce the anxiety, would settle in the tremors features. So that can easily be settled. Besides, when we talk about benzodiazepines, they also act on the GIT muscles and also cause some amount of constipation in high doses. So that is again beneficial in use here. So one thing that we can remember here is that benzodiazepines can clearly be used irrespective of the diagnosis. Either it is NMS, either serotonin syndrome, or even catatonia. So benzodiazepines are beneficial in all of these cases. Apart from it, for specific management, what is the drug that can be given? Serotonin syndrome occurs because there is a high amounts of serotonin in the blood or in the extracellular synaptic space because of the blockade of SERT uh, receptors. So we have to antagonize the serotonin that is present excessively. So we have to use a serotonin antagonist, an antagonist of serotonin that is across all receptors has an antagonistic property, which is one serotonin antagonist that has a global antagonistic action, that is cyproheptadine. So a drug we use to increase appetite in most cases commonly. Cyproheptadine can be started as a global serotonin antagonistic. Its doses, as mentioned in on your screen, starting with 8 mg and then increasing 2 mg every 2 hourly. So the doses can go up to 16 to 20 mg of per day, depending on the severity of serotonin syndrome. Besides that, the monitoring management of the hyperthermia and rigidity is necessary. There is not anything very specific about serotonin syndrome management apart from cyproheptadine and benzodiazepines. So anything, so Hiral sir can
I
add.
think uh, yes, it is covered. It is important to pick up serotonin syndrome early. To have a, it has a good chances of good prognosis if it is picked up early. And as Dr. Aditya mentioned, many times it may happen that milder versions are difficult to pick up at times. And if picked up, they can be managed on OPD basis also. But the severe ones, yes, they need to be picked up early. And as compared to NMS, I think then it is a better prognosis. So one is that, rapid onset after the agent, the specific differential signs of the neuromuscular thing, clonus, the hyperreflexia, and the tonicity. And in management, mostly it is about the removal of the offending agent and mostly managed by benzodiazepines and the supportive management, and watch for the other autonomic other issues, sorry, GI issues in that. And I think cyproheptadine we generally use in the severe cases, right, Dr. Aditya? In milder, we do we use it regularly?
Yes, no, no, sir.
So I think in mild and mild to moderate, even as moderate, Dr. Aditya mentioned, can be managed in the regular IPD settings, obviously with some monitoring. So use of cyproheptadine is for the severe cases is generally kept. So I think it is easy to manage serotonin syndrome. It's just important that you pick it up early. That becomes important. Right now, the question I would like to discuss is that one, after the NMS is resolved, when will you consider starting the antipsychotic? And second, once the serotonin syndrome has resolved, what about the restarting of an agent? What agent would we prefer, or would you like to give a re-challenge of this same or the similar kind of agent? I think I would like the participants to come up with their answers or share their experiences. A re-challenge after half-life time cleared off. Sudesh, in which condition are you talking about re-challenge? In NMS, re-challenge of the antipsychotic, or in serotonin syndrome, the re-challenge of the serotonergic agent? NMS. Okay, with the same agent? Yeah. So if required, it could be in NMS. Yes, consider something that has low dopamine blockade. But I want to ask that how far will you wait after the resolution of NMS? How long will you wait? Or what could be the earliest period if someone asks in severe cases whether it is required only, then 2 weeks. Okay. I think as early as 5 to 7 days has been documented, if I'm correct. But yes, generally they say that keep a period of 2 weeks and try to manage with benzos or other agent for the agitation during that period of time. And in NMS, 5 days for oral and 6 weeks for depot. Fair enough. The depot preparation, yes, it becomes very important whether the what route the antipsychotic was given. Good. And what about the serotonin syndrome? Okay, Prabhati has mentioned that same agent can be used with low dose, and Raj has mentioned that short half-life drug in serotonin syndrome. Okay. Dr. Aditya, would you like to, uh, answer this and finally sum up?
Yes, I think NMS, the usual period is 2 weeks because that is the time we also give the dopaminergic agents. And for serotonin syndrome, I think we can, after settling in clinically, we can start. I'm not sure about the exact duration that is
Duration.
needed, but depends on the half-life for, let's say, considering if there is a reaction on fluoxetine in this case, we need to consider the long half-life of fluoxetine and go for a longer period of 4 to 6 weeks. Besides, serotonin syndrome usually occurs in patients with depression or OCD. So we can have a watchful period of a longer duration. In NMS, we might have a very highly agitated patient, psychotic patient. So a starting period can be, has to be taken up with much more caution. That can also be a clinical factor to take in.
Right. So the half-life of the agent that were used as a serotonergic agent, it becomes very important. The washout period, especially, what Dr. Sagnik talked about, prenylcypromine, the MAO inhibitor coming back, making a comeback. All those things, the washout period needs to be very important. And one person really mentioned that, clearly mentioned a fluoxetine. Yes, it is a long acting, as Dr. Aditya mentioned. So you have to consider that 2 to 3 weeks at least of wait. And in the meanwhile, you can manage symptomatically with other things, or if there is a severe risk of suicide in anything, obviously there are other modalities of management for that. But yes, it becomes important that you understand, one is polypharmacy of our own antidepressants, as well as combination of our antidepressants with other serotonergic agents. This is important when it comes that whenever you are evaluating the possible offending agent for serotonin, because all those combination also needs to be considered. If you restart and again the patient land up into same combination, again the chances may be there. Yeah. So Dr. Sagnik,
So yes, sir.
anything specific would you like to add, or any your suggestion or opinion? And I think then we can summarize both the
Well,
cases.
I think we can summarize, sir. Just one thing that is that like it the re-challenge, I mean restarting of the agent. Suppose my patient was on haloperidol, and patient was like, and I find that patient is obese or having metabolic syndrome, patient is having hyperprolactinemia and other things, then definitely, and it's a chronic patient, and we're having breakthrough auditory hallucinations even while being on any antipsychotic or anything like that, and definitely I will like to again rechallenge with haloperidol with generous dose of THP, because as I mentioned in my first case that THP was something that was missing, and maybe I will start low at 2.5 mg haloperidol, maybe go to 5 mg with 2 mg THP or 4 mg THP. But again, I will like to do that in a government setup. If I'm in a private setup, then I will definitely like to go with trifluperazine or maybe something like that, which is a little bit less potent, because so batting in front foot like Virendra Sehwag becomes like Rahul Dravid when we are in private practice. So that thing is also there, sir. So, but yes, as the washout period, we must keep in mind, and this question actually keeps on coming up in MRC Psych also many times. The half life of paroxetine, half life of fluoxetine, half life of sertraline, half life of various antipsychotics like olanzapine, risperidone, and all. Why? Because we need to make sure that at least 5 half-lives are completed for a particular drug, for complete for the drug to reach half of its normal level, and after that for complete washout another half. So if I take a drug like say olanzapine, which has a half-life of 24 to 32 hours, and the drug like for 5 days I can wait, and for to reduce to half, and another 5 I will wait till one fourth is reached, and then I can re-challenge. So the half-life monitoring and knowledge about it becomes very crucial whenever we are planning to re-challenge a patient on the drug. And also, as you said, sir, the polypharmacy part, we can start with a some serotonin sparing agents are also there, like NDRIs are there, like we have bupropion is there, and some serotonin sparing agents are there, which we can also consider if a patient is at high risk of developing serotonin syndrome in that manner. So I think Aditya sir and Hiral sir, if you can kindly sum up this session of like, because we have discussed starting from for the last 2 hours, we're discussing starting from NMS till migraine catatonia and serotonin syndrome. If you can kindly sum up, sir, then yeah.
Dr. Aditya, please. And specifically because you're very good at helping the residents from clinical as well as from exam point of views, pointing that. So I like that approach of yours. So
Thank you, sir. Just trying. So yes, so we'll discuss three main diagnoses today: NMS, malignant catatonia, and serotonin syndrome. Three important emergency situations that one can face. From theoretical point of view, NMS is a thing that you have to remember, and serotonin syndrome the second most priority. And catatonia in itself is a major thing to remember. So all the three can come as a part of theory as well as your viva questions. And apart from it, the major clinical point to see is NMS will occur in presence of neuroleptic, serotonin will occur in presence of serotonergic interactionable drugs, and malignant catatonia in the presence of catatonia and the overlap of some NMS symptoms. For both NMS and serotonin syndrome, you have to remember the criteria that you have to uh, just wrote it down. And in the clinical features, the tetrad of NMS, you should remember to diagnose hyperthermia, rigidity, autonomic fluctuations, and the use of a neuroleptic syndrome, a neuroleptic agent. And for the fourth point is the diaphoresis. So diaphoresis, autonomic fluctuation, rigidity, and hyperthermia for NMS. And for serotonin syndrome, the presence of clonus, spontaneous or inducible hyperreflexia, and GI disturbances. So these three things you can easily remember. For apart from management, benzodiazepine is common throughout all. Dosing can vary. For catatonia, much higher doses and milder doses for NMS, serotonin syndrome. And specific management for NMS would be for supportive care, managing the complications, saving the patient. And next would be specific agents for dopaminergic agonist, including the bromocriptine and amantadine, and muscle relaxants, that is dantrolene, and the second option would be baclofen. For serotonin syndrome, only specific agent you should remember is cyproheptadine. And ECT again is a common choice or last modality of treatment for malignant catatonia and NMS.
Right. Hiral sir, will you like to sum up this?
yeah, so I think Dr. Aditya summed up well. So there's a couple of things. One is that I would request every JR to go and read this, but more importantly, be very vigilant when you are in the emergency room with the physical examination and the neuro examination. Many a times it happens that as a psychiatrist, it happens. And I'm not saying that anyone does on purpose, but I just wanted to highlight again and again the importance of this basic things of physical examination and neuro examination. Actually, they're a part of MBBS itself, not part of specialty. But yes, they are very important, even if a subject is concerned. And many a times I would say that do this so that you can even confront at times your neurology SR. Many a times they want to dump the case or transfer the case or shift the case, if I put it in the softer words. So it's always better to have a grip on all these aspects as well. And yes, managing those, I don't know how many would you would see serotonin syndrome or NMS in your setups, but the point is that when it comes, you should be at least aware that this is what you need to think of. And as JR, I would say, whenever you're managing in an emergency, with an SR or with your senior, manage, read the book, manage, read the book, discuss, manage. There's no shame in doing that. And once you do that repeatedly over a period of time, I think Dr. Aditya, Dr. Sagnik would agree that then you don't have to put much pressure in the examination to remember it. So that routine practice of reading, applying will help you a lot. So again, thank you everyone. Thank you, Dr. Aditya. Thank you, Dr. Sagnik, for the cases and for the all the wonderful notes. And thank you all the participants. And I'm hopeful that Dr. Sagnik has further more exhaustive list of such clinical scenarios
Yeah.
that we'll keep on touching and addressing this. Right?
Just one small thing
Sure.
actually is that whenever in the ER, like as sir said, that to confront the neurology SRs. So I'm going to be a little bit honest over here, because from the
That
medical point of
was
view,
merely a part of I won't say a joke, yes, personal
no,
experience, but I wouldn't push
it's
Jazz
actually
to do
true.
that.
It's actually true, because like, let's be honest, neurology, from most, although they're my friends, when it comes to clinical cases, there have been many discourses, and there has been some ego clashes also, to be honest, and these are very common actually. So the main thing is that when you're approaching such a patient, as the sir said, with we don't have, because we don't get the investigations right away. We don't get the investigations like TLC or CPK that right away. Maybe a small demonstration of Kerning signs or Brudzinski sign, those things which are signs of meningeal irritation, and some like inducible clonus, like how to induce a clonus, or how to check for clonus, to how to check for hyperdeflexia. Small things that we can actually perform in the emergency setting, they can go a long way actually when we are confronting our neurology colleagues. So these are okay. So Koholi Flower has asked how to check for ocular clonus. So
I think Dr. Sagnik, we can address, have a separate demo classes if required,
yeah, actually, me and Aditya sir
for the
already
detailed
have
things.
something
Yeah,
planned
so in the
regarding
app
this.
also
So
or here also, because
those
this
will
is just
be
one part. There are a lot of other things that require demonstration. So,
many
yeah,
other inducible signs are
it's
there.
a good question, but I think we can cover it separately.
Absolutely. Thank you, Hidal sir. Thank you, Aditya sir. Session was very comprehensive, and I think we touched on all the points. Aditya sir beautifully summed up the etiologies, the approach, the investigations, and the differentials, and the management of all these things. So thank you, everyone. Thank you, everyone, for attending the session. And thank you, Aditya sir. Thank you, Hidal sir. And I hope we keep on meeting like this and discussing newer cases for the benefit of the residents. And just one small announcement actually before we go, that if you are an exam going resident, or any of your seniors are exam going residents, the conceptual psychiatry Q&A bank notes are out. So all the notes has been made from our own app notes, which are again referenced from standard textbooks like CTP or Rutters or Lishman. So it has been made from a very exam oriented point of view. So orders are still going on. Many students are still ordering. Even the residents who are going to appear in next year's exam, if they want to kickstart the preparation now, they can also order, because almost all the topics have been covered. And so you can just go and check it out. And thank you very much for attending to the session. Thank you, sir. Thank you.